Good morning. Welcome to the Tyro MDS, our next tumor board. I'm Mike Tuttle. I'm going to try to moderate this. I don't know how well this is going to work based on my panelists, but we're going to do our best here. Let me have you flip to the next slide and we'll introduce our panelists. And we'll just go around the, let's just go in order here, starting with Dr. Pasieka. We'll go down and let folks just introduce themselves. Janice?
Yes, I'm Janice Pasieka. I'm a surgical endocrinologist at the University of Calgary. It's a little early in the morning, but I'm sure Dr. Shaha will wake me up with the first question. But thank you for having me.
I'm afraid so. Dr. Baloch.
Hi, my name is Zubair Baloch. I'm a professor of pathology at University of Pennsylvania Medical Center in Philadelphia, and my specialty is endocrine pathology.
Dr. Alexander.
I'm Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital in Boston.
Dr. Khorsandi.
Azita, Khorsandi, radiologist at Mount Sinai.
Fantastic. Dr. Wirth.
Hi, everyone. I'm Lori Wirth. I'm a medical oncologist at Mass General Hospital in Boston.
And it's my pleasure to introduce the famous Dr. Shaha, who I've had the pleasure of working with for 23 very long years at this point. We've worked together quite a bit. Ahok's quite a famous head and neck surgeon with broad expertise in thyroid cancer from Memorial Sloan Kettering Cancer Center. So Ahok, if you want to go ahead and bring your slides up and we'll get those started. We're going to have Dr. Shaha present the cases and start the question and answer session. I will be watching the Q&A session. So if there are questions that come in through the question and answer, just put those in and I'll bring those up to the panel as well. All right. You're good.
Okay. Good morning, everybody. As Mike Tuttle said, I've been working with him for 23 years. We're going to have case presentation. I'm going to present two big cases and get some opinion from the experts, and two small cases just to show you some different presentations and the complications. So let me just start. I have nothing to disclose except this. I've been working with Mike Tuttle, who is probably the best endocrine surgeon in the world. Had no complications, no nerve injuries, no parathyroid problems, and all success and glory. So you can imagine that working with him has been one of the greatest pleasure. Since he joined us, I think our whole approach towards thyroid cancer changed. Before he joined, it was me and myself. Now we have a reason to believe that there are other specialties who can make a major impact in the management of thyroid cancer, even though we do believe it is a surgical problem. Okay, so I'm going to start with the first case. This is a very straightforward case. 44-year-old gentleman presented with hoarseness of voice. The fiber optic laryngoscopy showed left paralyzed vocal cord. And there is a 3.2 centimeter mass in the left tracheoesophageal groove. Azita, what do you want me to do this?
I prefer a CT of a neck.
Okay. Is there a role for ultrasound?
Yes. So
tell me between the two.
Between the two, I would start with CT because of the size of the mass.
Mm-hmm. Okay.
Because at this size, you're going to have to put a needle in this anyway. So I would start with the CT, especially since it extends into the, because of the vocal cord paralysis. It already has declared itself that it's probably not a benign lesion.
Let me change the subject. When would you not want to do the CT?
If I have, honestly, if I have a good ultrasonographer,
yeah,
you can stay with ultrasound. A skillful ultrasonographer can map out the lateral compartment, map out the central compartment, and also tell you if there's extrathyroidal extension of the lesion. So I really do believe in ultrasound, but you really need to have a skillful ultrasonographer.
Janice, one of the common questions that comes up is CT or MRI? As a surgeon, what do you think, Janice?
Yeah, I think one of the things you may be getting at is the iodine load. If you're going to think that you need to give radioactive iodine right away, and I'd have to defer to the medical oncologist and endocrinologist, because here we've sort of decided if CT is a better way, than an MRI based on what you're trying to see, or we can get it faster. Not to get a second class test just in case you need radioactive iodine. And I just want to point out that I agree that the ultrasonography is great for the lateral nodes, but what I need to see from a surgical point of view is that pretracheal prevertebral fascia, and to looking at its resectability of the trachea. And I'm not sure that ultrasound, at least from my perspective, gives me that confidence to know if it's what I'm going to get into when I'm actually there. MRI is helpful as well. We just get CT faster here than we do an MRI.
I think
And the test is also important to get, not just the head and neck, looking for metastatic disease, because that may change your approach should you get into trouble in the operating room.
I also like CT because I think I can interpret it better than going to the radiologist and trying to learn more about the CT. Okay, so as I mentioned before, his vocal cord is paralyzed on the left side. It's in the mid-abduction position, and there is a ill-defined mass in the left tracheoesophageal groove area. So we talked about the imaging. I'll show you the CT scan in a minute. Zubair, is there any role for molecular markers here?
So I think, yes. I think of what the molecular markers do, it kind of supports the clinical and radiologic impression, but it kind of refines, and I bet this mass on FNA will be malignant, the way it sounds like. So it will be Bethesda 6. But what the preoperative molecular testing on that little FNA specimen will really help to define what type of tumor you're dealing with. So it can be either like a BRAF-like tumor or a RAS-like tumor. And if there is a layering of more molecular, there is fusions or something else like a TERT promoter and stuff, then you know that this is going to be a more aggressive tumor. And it kind of also tells histology, our pathologists, when you're grossing this specimen, what you're going to be dealing with, and you know how many sections to take. And it kind of refines also the histopathologic diagnosis. So I really think doing molecular markers now, granted, when you do the reflex testing on molecular, on FNAs, you cannot do it. It's not approved for Bethesda 6 categories. It is approved for Bethesda 5, most of them. So you may have to do an additional test on that specimen, or you wait until it comes out. So definitely, I think it is. It just depends upon the role of the clinician and the patient, and you know who's going to pay for it and whether it's necessary in this case.
Well, Lori, let me take you down that molecular rabbit hole, because now every time we see these big tumors, these hard to think, we're thinking about neoadjuvant and we're thinking about shrinking and that sort of stuff. Where do you where should we be thinking about that, Lori?
I'm glad you asked. I was chomping at the bit to talk about that. So I agree completely that, you know, we care a lot about the molecular diagnostics here in this case, because, you know, this sounds like it's going to be, you know, certainly an R1 resection. Also, it's a young person, so more likely to harbor an actionable fusion. There are now clinical trials looking at neoadjuvant therapies. There's a neoadjuvant selpercatinib trial. So I definitely would want to know if there's a RET fusion in this relatively young person. And then there's also a neoadjuvant lenvatinib trial underway that is molecular agnostic. And I think, you know, there's real opportunity to improve the surgical outcomes, particularly since, you know, we know that he already has vocal cord paralysis. I never really thought that hoarseness was a big deal until I started to talk to patients who live with hoarseness, and it can affect one's professional life, one's life at home in really profound ways. And so if neoadjuvant therapy can improve the vocal fold function in this patient, that would be meaningful. Of course, we don't know yet, that we have to do the complete.
I think our experience with the vocal cord paralysis coming back to normal is very limited right now. You know, so I think it may be a little bit too early to say that the neoadjuvant therapy is going to improve the vocal cord function. If it is paretic, probably yes. If it is totally paralyzed, I'm not 100% sure, but I think that's a good point, and I'm sure as we gather data from many institutions, we'll learn more about it. Erik, fine needle or core biopsy? A lot of literature in the recent publications.
I mean, I think the
Alexander?
starting point is always a fine needle aspiration, and you ask yourself, does a core biopsy add to that, or do you need it for molecular analysis you can obtain otherwise? But in the moment, an aspiration is so easy and will help just solidify what you think is going on, and I think I'd start there.
Zubair, would you be more comfortable with the core biopsy and the histopathology versus cytology?
You know what? I think I will go with Erik, because I think the fine needle aspiration is a very thin needle. You can get the diagnosis, plus you can always do extra passes to get a good cell block. The material that this specimen is collected in lends itself for molecular analysis, and it can be done. So for me, it's like doing a core, and the core biopsy, remember, it's targeting only one area. And if this tumor is fibrotic, is infiltrating, you may just get fibrotic stuff and muscle on a core biopsy, and you may not really see that much tumor cells. So for me, plus core biopsy has its own problem. So I think fine needle aspiration is the way to go, and you just do extra passes. So for me, that will be the best approach for this patient.
So I just wanted to show these pictures. The ultrasound showed a mass about 2.5 centimeter, which could be literally inseparable from the cricothyroid area in the trachea. Azita, can you tell us a little more from this CT? This was done outside. Number one, can you tell us what is going on? And the second question I have is, should I repeat a CT in my own institution? This was done 1 week before patient came to us.
Okay, so let me first answer the second question. No, I would not repeat the CT. I would just upload it and get it reinterpreted in-house. One of the things that you're not showing is the status of central compartment in this examination. And also I'm not seeing the entirety of the lateral compartment, but the primary lesion, the way it extends into the left tracheoesophageal groove, I am worried about extrathyroidal extension. I think we're okay with trachea. I can see sort of the trachea. I can see a sliver of normal thyroid tissue, quote unquote, normal thyroid tissue between the lesions. So I don't think there's tracheal invasion. The esophagus, I cannot evaluate based on this, or no one can, what is happening actually at this time to the esophagus.
Okay, so I think, this is a very important point. We did not repeat the CT. Plus, we didn't want to give too much of the too much of the iodine again. He already had a CT of the chest. You didn't see the lateral neck, but that is negative. The central neck is also negative. The needle biopsy was definitely papillary carcinoma. They couldn't define anything more than that. We had a gut feeling this is going to be a little more aggressive than classical papillary. Janice, the patient's vocal cord is paralyzed on the left side. Are you concerned about operating on this patient?
Well, I think any surgeon should be concerned because,
Send it to Dr. Tuttle. He will take good care of
yeah,
it.
Dr. Tuttle with no complications is the man to do it, isn't it? Yeah, you have to be concerned because it's gone. And I don't think there's any way you're going to be able to bring it back to life. So you really are left with one nerve. And obviously that needs to be protected, because if that is in any way injured or has apraxia, then they're going to need a tracheostomy, at least temporarily, for breathing in the original post-operative period. So this is where you want to make sure that it's being done by experienced surgeon, and the utilization of the nerve monitor could be very helpful in this situation, at least indicating to you whether you have your right nerve is functioning at the end of the case, I think would be important.
Great. Lori, out of frustration, I'm going to send the patient to you, because I know I'm not going to be able to do a great job. What is your advice to me and the patient?
Well, of course, surgery is the optimal initial approach, and particularly to allow for the full diagnosis of exactly what kind of tumor this is. I doubt that there's an anaplastic component,
No,
but
there is no anaplastic component.
yeah. Oh, you've already operated on the patient?
We did the operation. My major concern is we always talk about neoadjuvant therapy, and there one of the questions that goes through in the tumor board is, are we going to lose the window of time? Means, is it going to happen that after 2 months or 3 months of neoadjuvant, we lose the good resectability? What is your thought process? And Janice, can you elaborate after Lori gives the answer?
So there are those 2 neoadjuvant trials that I mentioned. Both of those drugs, lenvatinib and sulpercatinib, have very high response rates, and that's an advanced disease. So we don't yet know what the neoadjuvant response rate is with lenvatinib, for example, in patients that have had no treatment for thyroid cancer, but it's going to be at least as good. And in the SELECT trial, there were 80+% of patients had some tumor shrinkage. So the risk of losing the opportunity for surgery is exceedingly low. The same is true in RET fusion positive cases. The objective response rates with sulpercatinib are so high that losing the opportunity due to tumor growth to operate is really highly unlikely.
Great, that is good. Janice, anything to add to that? I think she said it very well.
Yeah, no, nothing to add. But can I ask, is anybody concerned that, we have this aggressive primary and there's absolutely no lymphadenopathy in the central or lateral compartment, that there's something different about this?
Zubair, can you expand on that? And maybe Erik can answer.
I will leave it to Erik. Erik, go ahead for this.
Yeah, I mean, I think it's notable. I think it's a great point. I mean, what you can, I guess, say here, certainly from the CT, is that you don't have bulky adenopathy, but you often will find small, lymphadenopathy on histopathologic review. So, I mean, I would also be thinking about distant disease. I think you had mentioned a CT of the chest was done early on, but that's certainly on your mind.
That's a great point, Janice. So when we're looking at what looks like invasive disease, it's hardly ever just the invasive disease, right? So going back to the CT scan, going back to the ultrasound. Dr. Rossleigh, I see we have our electronic challenges fixed here. Give me one sentence who you are, then I want to ask you a question.
Oh, sorry. I think the time zone differences have changed, because I think you guys must be on daylight saving now, are you? Okay, sorry. So I'm a nuclear medicine physician and I work at Prince of Wales and Sydney Children's Hospital, and I look after thyroid cancer patients in our institution.
Monica's a great friend, and before she signed on, I told the panelists I never get this right when I'm trying to sign on with something from Australia. Monica, let me ask you, this was a 44-year-old gentleman that had a locally invasive papillary, taking out the nerve, kind of pushing on the trachea, not invading the trachea though. Any role for upfront PET scan imaging on a case like this in a 44-year-old? We don't really know what it is yet, but would you think about that, or how would that help us?
We don't, as a routine, do PET scan at staging, but if there's significant concern, then you could do a PET scan to look for a more aggressive disease. In general, we wait for the histology and surgical findings and then decide whether to do a PET scan, but it can be done if you've got significant concern of aggressive disease.
Okay,
Ahok, back to you.
Yeah, so we brought this patient to the operating room. Don't criticize the surgeon because it was me. So at the time of surgery, the whole tumor was, it had a broad front against the cricoid cartilage, cervical esophagus. We were able to get R0 resection in my mind, but I'm sure pathologically it is not going to be R0. I took out all the gross tumor, which was stuck to the esophagus, to the trachea. The esophageal part of the esophageal musculature had to be dissected. And one of the things our pathologist, Ronnie, said is there is a positive margin in the broad front. And he raised the concern that have you done a good operation? That was his first question. And I said, yes, I did the best I could. But he said, I'm very concerned about this patient because there is a broad front on it. And I think I didn't realize this till he told me in this particular case that the broad front is very important. Janice, you want to expand on that a little bit?
I don't know if I can. I'm not quite sure I understand what we're talking about.
Okay, so the tumor was adherent by about 2 centimeters in a vertical length. And even though all the tumor was removed, the positive margin was not 2 millimeters, it was 2 centimeters.
Right. Yeah. So the whole tracheal margin is positive because
Right.
you've essentially shaved it off. So you have microscopic disease in the area where they're going to recur. And this is where multidisciplinary tumor board and surgeons saying, listen, there's disease still left there. The pathologist can confirm it. Let's not pretend that there's a high chance that something's going to come back and we need to be aggressive.
Sure.
Yeah, let me just reemphasize that point, because Mark and Margie and several of us are working on a paper that sort of, how do we do that communication between what you guys find in the operating room to not only 10 days later when I see them, but to the pathologist. So Zubair knows where these margins and stuff are about. What was gross resected? Where were you scraping stuff off on? The rest of the team needs to know that downrange. So we're working to try to come up with a checklist or something that as soon as it leaves the operating room, the pathologists know not only where they came from, but what did you leave behind and where their margins. Because what I hear you saying, Ahok, is you got a gross complete resection. That's your version of R0 in your mind. Cool, I need to know that. But then Zubair is going to see that margin positive. It's going to be stuck everywhere. You may not have sent him a piece of the trachea, right? You may not have sent him a piece of muscle, but if he knows where you scraped that off of, now it's a more complete picture.
Sure.
Right, back to you.
Occasionally, we have put the clips in that area, so that the radiation oncologist later on knows exactly what the problem is. Most of the time, it is pretty easy because you have got preoperative CT scan. So this is the final specimen, as you can see. Zubair, you want to just expand on that? Positive margin here all around?
Yeah, so I mean, for me, regardless of what subtype it is, it was metastatic, so definitely malignant. For me, looking at this tumor on this low part, and this is a great picture to really show what we look at. It is an infiltrative process. It is back-to-back tumor cells. So tumor is very denser with fibrosis, which could be intratumoral or because the tumor is infiltrating. And what Ronnie was pointing out to you, if you look at the top of this, this tumor really is infiltrative very broadly. Plus, it's not just one area, it's very multifocal.
Right.
And to me, that really matters. And Lori knows that I sit on a couple of committees with her, and I always point out that that information from the surgeon, most of the time, we don't know what margin is what and what they saw grossly in the operative room. So I have to shuffle through operative notes to find it. So I think this will be very important in this case. And you can also see this tumor is going out in the fat. So regardless of the subtype, regardless whether I say this is just a papillary carcinoma subtype or it is one of those high-grade non-anaplastic, to me, this is a very aggressive disease. And
That's
to
correct.
me, that's what matters at this point in this case.
I think, the point that you brought up is very important, and Mike brought it up. The minute I finished the case, I picked up the phone, called Mike, that this patient is going to be seen by you as soon as you can. And I called Rani Hussain that, look, I'm not very happy with this. And that's what he illustrated in the final pathology report. And he did write that the broad front, the tumor is positive in the broad front. So this is the pathology. Zubair, go ahead.
So, I mean, it is papillary carcinoma. It is completely papillary formations. There is no follicle formation in this. I also like that it's very complex. It's a very dense tumor. It is very solid tumor. And as you can see in the middle of it, if you see the nuclei are kind of facing each other, so they are what is called as a tram track appearance in this tumor, and they are a little pinky. So this is features that are reported in tall cell subtypes. At this point in this field, I do not see any mitosis or necrosis. So it is a papillary thyroid carcinoma, and I will favor this is a tall cell subtype or features of tall cell subtype, and which kind of matches with what you showed on the low power also.
Yeah. Dr. Rossleigh, what's the chance that this patient will eventually, if we had left him alone, would have developed anaplastic thyroid cancer?
I don't know if I can answer that, but I would certainly offer radioactive iodine in the post-operative setting
Okay, so
as adjuvant treatment.
okay, so one of the common question comes is in this patient, which is locally aggressive, the surgeon has done the best job, but not very happy. Radioactive iodine first or external radiation therapy first? Erik, you want to just expand on that a little bit, and then we'll ask Mike. Mike has a lot of experience with these kind of cases.
So my feeling on it, and then Michael, correct me if I'm wrong, is I think if you ever do push into external beam radiation, you should really discount the need for true radioactive iodine 131. That would really prevent further uptake. But I do think the wild card in this case as well is that you're dealing with someone in their mid-40s. And if there's kind of one variable that seems to override so much in well-differentiated disease, it's that young people do better, and they often tend to have more iodine avidity. And so I think it's absolutely worth a shot to consider it if you feel the window of waiting for the CT contrast to wash out is not going to sacrifice something. But I would also be talking to Lori and my other colleagues about, just the question of other MEK inhibitors, and is there a way that we're thinking about increasing iodine uptake? Because that's very much in front of us these days.
Great points. Mike, you want to just elaborate what you do most of the time?
Yeah, exactly what Erik says. I mean, I think anytime you have gross extrathyroid extension, you at least have to think about external beam regardless of the age, right? I mean, that has to be on your thing. You can probably count on one hand the number of times I've given external beam upfront to 30 early 40-year-olds. It just seldom does it. So yeah, I'd be thinking, I'm agree with Monica, I'd definitely give a dose of radioactive iodine. It's way off label, but if they had a targetable mutation, I might even put them on something before we gave that first dose of radioactive iodine. I mean, even for us, we don't traditionally do that, but this case, I'd probably be thinking about it. I'd make him fail that before I gave him external beam radiation. Often do a PET scan about 3 months down the road, just looking for really hot recurrence. Like, did I really miss the boat? Knowing I'm going to see that post-operative changes. So in a young guy like this, I'd be leaning him toward upfront radioactive iodine. I watch his neck with PET or CT every 3 months for the next year, and looking for like have a low threshold to go, oh, bummer, you're that 1% that needs external beam. So, and amazingly, as Erik was saying, most of these guys don't need it. They recur, but they recur 10, 15, 20 years down the road, and the recurrence is usually still treatable. It's seldom they actually recur in the trachea or through the trachea. It's more lymph node met. So, yeah.
Lori,
so we're
I operated on this patient today. When should I call you?
Call me right away. I'm with Mike that we would consider in this young person totally off-label, totally illegal redifferentiation with initial therapy. I'm all excited because he's BRAF negative and his age. So is there a RET fusion? Is there an NTRK fusion? There have been case reports of the RET inhibitors and larotrectinib, the TRK inhibitor, precipitating iodine uptake in iodine refractory disease. We do now have a trial looking at selpercatinib in RET fusion positive iodine refractory disease, not in the adjuvant setting like this. And I think I have to say that the one adjuvant redifferentiation trial, Astra with selumetinib, a MEK inhibitor, was negative. So we have really no data in this setting, but it's something that is tantalizing to think about.
Well, while Ashok gets ready to go to the next case, let me ask one question out of the chat. There's a question that says, does the percent of tall cells correlate with RAI avidity? Zubair, can you talk about sort of tall cell features versus tall cell, what do you guys call them, subtypes or something now? And does anybody know that relationship if there's any RAI avidity? Zubair?
So, I think what is the avidity stuff, what I personally have seen and what is also reported in the literature. So first of all, you can only call a tumor outright tall cell subtype of papillary thyroid carcinoma if there is 30% or more of tall cell histology in that. Yes, I think, and this is also recommended, that any features of tall cell subtypes you see, and there's a lot of variability, what is called tall cell out there. Also, you should mention it, because in good majority of cases, the tumor that metastasizes is going to be that tall cell subtypes. And there are cases of tall cell subtype which are not radioactive iodine avid. That means they lose their supporter mechanism. So for me, that is very important to mention. Also, what happens, like in this case, sometimes when the area where the tall cell is located is usually at the infiltrative margin. And we know that the tall cell subtype, as compared to classic papillary thyroid carcinoma, has more ability to become anaplastic. So anaplastic carcinoma is more commonly seen at the infiltrative edge. So for me, the bottom line is, if you see it, you should mention it. You can always take an approximate percentage of it if it is below 30%. And I actually even mention in my reports, where do I see tall cell? I will say the infiltrative edge, what I see, the positive margins. So I think that in that sense, it's important.
One last question before we move on, because this is a good question from Dr. Iyer. So how do we justify redifferentiation really in this adjuvant therapy setting? And I think you heard Lori and I re-justify it with a long sentences that says, don't try this at home. This is not definite. So nobody really knows whether this works yet or not. We're just telling you in real practicality what we do at our specialty centers. I will tell you, our general approach at Memorial is not to do it in the adjuvant setting in sort of the off-label case. So even for us, this would be unusual. But it's an unusual case, and it's 44, and it had a broad front. So I think your point is well taken. This is not ready to try at home, but we're just being honest with you and tell you what we think about it. Okay, Ishak, we're halfway through.
Monica, one question. The dose of RAI, just give me a number.
Oh, somewhere between 100 and 150 millicurie.
That's what the surgeon thinks all the time.
You said 125. You were right again.
You will be absolutely right. Just remember that number, 125. You'll never go wrong with that. Okay, so let's go to the second case. This is a little more complex, and this is again my case. I operated on this gentleman when he was 50-year-old in 2018. A 4-centimeter tall cell, big tumor, gross extracellular extension, adherent to the surrounding areas. All gross tumor was removed, and you will see here he had extensive bilateral nodal disease, and the nodes were as big as 3 centimeters with extranodal extension. 44 nodes were positive. Zubair, can you tell us about extranodal extension between thyroid cancer and squamous cell carcinoma?
Okay. So, I think extranodal extension matters in thyroid cancer. I think any form of cancer that you see in head and neck, I think it's an important feature to mention. Also, the size of the metastatic deposit that you see in a lymph node, that is also important because it decides the magic number between micro and macro metastasis. I think when you see, as compared to squamous cell carcinoma, I think it tends to be the extranodal extension tends to be more broader. Extranodal extension in thyroid cancer can be focal. But I also think there's a lot of variability, what is called as extranodal extension. So you have to be very careful, because I have seen cases, and I'm sure the other pathologists have also, where there is no extranodal extension or vice versa. So I think it's an important feature to mention, but I think it's also important along with the size of the metastatic deposit and the largest lymph node involved, which really it matters more in thyroid cancer as compared to these squamous cancers.
By all means, this is a very high risk thyroid cancer. You can see here multiple nodes positive. He did receive, his surgery was quite satisfactory. There was no gross tumor left behind, and the surgeon was not terribly concerned of future recurrence, even though deep in my heart, I know he's going to recur sooner or later. So he received radioactive iodine. Is there any role for external radiation therapy in this patient? Who wants to take it? Monica, any role for external radiation therapy?
I would
we already
not
gave
think
him RAI.
at the present time, I mean, at the time of when he initially presented, I don't think so.
Okay,
I think just the radioactive iodine.
right.
That's what
we
would
did.
happen. That's what would happen in our institution.
Right. Azita, how would you follow this patient? What kind of imaging you would want to do?
I would do PET CTs on this patient.
Okay.
And there's one more thing I've been meaning, I don't want to interrupt. The reason CT is very important and we all prefer it, I think we all forgot to talk about this. Patients present with retropharyngeal lymph nodes. You can only see it on CT,
Good.
not ultrasound. Of course, you'll be able to see it on MR.
Yeah, excellent point. You know, we have seen patients with a high parapharyngeal disease. And, if the CT was not done, we would have missed that. And 6 months later, somebody does the CT and there is a big Goomba there. Doesn't feel very good that we didn't evaluate the patient fully. So this patient, this is the initial presentation here. You can see here, big tumor with gross extrathyroidal extension, the tumor involving the isthmus. There is a tumor on this side. Both the nerves were preserved. And as you saw that the bulky nodal disease. This is the gross specimen. I won't take much time, but you can see here large primary tumor. Zubair, anything to add on this? Let me just show you some others. Tall cell. Anything to add?
I mean, it's again a very aggressive looking tumor, and it's the tall cell subtype with, it confirms the extrathyroidal extension, what you showed.
Sure. I think, it's very interesting when you say this is a high grade tumor. Most of the surgeons can tell in the operating room what is a high grade and what is not a high grade. And that's why we call unhappy surgeon, unhappy pathology, and unhappy patient. That's a combination that is the worst combination in thyroid cancer. So this is a positive node. You can see here more than 3 centimeter large positive node. Anything to add on this?
No.
Okay.
Yeah.
Okay, so he did very well from 2018 to 2021 when his thyroglobulin was increasing, and the recent PET scan showed a bulky disease in the supraclavicular area. Let me just show you the CT scan. You can see here there is a disease in the paratracheal area and bulky nodal disease. These nodes in the supraclavicular area were clinically palpable. When I felt it, I said there is no other way than doing another surgery. It is very, distressing to the surgeon that he has to reoperate his own failure. But we knew this on day one that he's going to fail. So what else could we have done? Lori, what else could I have done? Or this is something that I cannot change the biology.
You could have had Dr. Tuttle do the surgery.
Send the patient to Janice.
We should stop the tumor board right there. That's a mic drop. Thank you, Lori. We're done.
Yeah, this is bad biology.
I think
What I would want to know before you do the revision neck is what's happening distantly. If there's a teeny tiny little lung nodule that in your heart of hearts is tumor, but it's teeny tiny and there are 3 of them, go ahead and take care of the disease that's going to be problematic soon.
Right.
However, if there's a lot of disease elsewhere as well, then the patient, you'd want to consider some systemic therapy.
He did have pulmonary metastasis, but they were small volume. He was seen by Alan Ho, and Alan did not feel there is any need to intervene at this time.
Yeah,
so because
that disease is going to become symptomatic. It's going to become problematic. So if you can get it out, that's great.
So since the disease was clinically palpable, I had to push him for surgery. He was asymptomatic, so he was not very interested in surgery. But after discussing with Mona and Alan, we decided to proceed with surgery. And now you will see here, we did undergo surgery. The tumor was adherent to the jugular vein. It was stuck to the jugular vein. We had to separate it. There was gross extranodal disease and gross soft tissue extension. And I think, to me, the soft tissue extension is the worst prognostic factor. Zubair, you want to expand on that?
No, I mean, I think the course of the disease, your findings on surgery, the pathology, I mean, it all points out to this tumor being a high-grade carcinoma. What my concern will be until I see the pathology is, what I will look for basically is to make sure that it has not transformed into anaplastic thyroid carcinoma.
Yes.
That will be my major concern at this point. And I will do appropriate stains, which is thyroglobulin and other differentiated markers to make sure that I am not missing an anaplastic carcinoma because, and I will just pitch in a pathology point of view here, if I'm allowed, that because this patient already had surgery done in the neck, right, in this area.
Yes.
So, and there's a lot of procedures have been done. So there's a lot of fibrosis and there's a lot of other crazy repetitive stuff going on. So as a pathologist, I try my best to make sure that I am not missing an anaplastic carcinoma. And once I exclude that, then this will be a high-grade follicular derived, because it's a follicular cell origin, non-anaplastic thyroid carcinoma. And then, that will fit what type of histologic subtype will be in this. So I love that category because it says it all in the name. And that's what relates to you and what Mike and everybody else.
Yeah. So this is exactly what we did. It was not anaplastic thyroid cancer, but you can see here, almost every lymph node is high grade. And there are 5 mitoses out of 10 in each and every specimen. This just tells us that this is not a good disease. Erik, the patient is with you now. You have been the endocrinologist. You gave initially 152 millicurie. Where do we go now?
So I guess I'd kind of reflect back. Local disease, if it's bulky, as Lori said, I kind of think that should probably come out because it's only going to cause trouble in the near future. He has known metastatic disease distant, I think you mentioned, but it was kind of indolent or small volume right now. I guess I'm trying to reassess post-surgically, where is he at again? And it's kind of this third staging system of response to therapy that's always in my mind, which is kind of where do you reset kind of the norm? Where's the thyroglobulin? How's he doing? I guess we're driving a little after the second dose of radioiodine question, which often isn't hugely beneficial. If you saw brisk uptake after the first one, maybe, but I think you have too much bulky disease here. I'm not sure you're going to get too far with that.
So you can see the lymph node here, and the entire lymph node is totally replaced by tumor. And I think this is where the pathologist will be able to tell us this is not good. Am I right, Zubair? You will tell me this is the whole node is replaced?
Yeah, so because to me, that is very important. It still looks like papillary carcinoma. And if you look at the bottom, in the middle, there is extranodal extension. So the tumor is outside the lymph node confines of the lymph node. One also has to be careful because sometimes on the metastatic deposits, you can have transformation of a well-differentiated carcinoma. So you have to make sure that this is, again, not turning into the lymph node or in the metastatic deposit. So looks like papillary cancer, aggressive, and there's extranodal extension, which is really nicely pointed out in this picture.
So Zubair, we started with the tall cell in 2018. Now it is high grade, 7 out of 10 mitosis. When is he likely to develop anaplastic?
I mean, I cannot tell you that. I mean,
I know that. That's why I'm putting you
I don't know, unless somebody has on the panel a magic answer. I mean, you can see both. What is it? I mean, I don't know whether this tumor was BRAF positive tumor or not. Because
BRAF and TERT. It is BRAF and TERT.
Yeah, so which goes with anaplastic as well as these high grade carcinomas. I mean, if we take away that, what type of tumor it is, we know this is a well differentiated carcinoma by architecture, by cytology, and by growth pattern. What is becoming more and more important in all endocrine pathology and other places also, that you really have to take into account mitosis or necrosis. Those are the ones which are really features of a high-grade carcinomas, and this really proves it. As beautifully pointed out here, there are multiple mitoses in this field. So for me, this will not anaplastic, is still well differentiated, but high-grade because of the clinical stuff and what the features I'm seeing on pathology.
So let me just do one sanity check here. The vast majority of tall cell variants never become anaplastic, right? I mean, there are thousands and thousands and thousands of tall cell variants. Lori doesn't see most of those, even though it feels like in clinic, that's our entire clinic. So we don't want to walk away with the impression that these tall cells always walk onto anaplastic. But alternatively, when we see the anaplastics, we're never surprised if they come from tall cells, but we also see them driven by RAS and other things. So I don't want folks to get the impression that all of these, but it's this case, the BRAF plus the TERT, the biologic behavior that's making us think down that pathway.
Okay, so we referred him for external radiation therapy. Monica, would you want to give another course of RAI, or you are going to say agree with external radiation therapy?
Well,
Remember one thing, after the second operation, I know deep in my heart, he's not going to get third operation anywhere.
So I think you could assess him post-operatively with FDG PET and either a tracer I123 scan to see if there's any residual iodine avid disease. If it's very FDG avid, that's more of concern that it's unlikely to take up iodine. So you could either do that assessment with imaging, or you could do a second dose of radioactive iodine and see if there's uptake. You're not going to lose much, because once you send him for external beam radiotherapy, then he's not going to get any more radioactive iodine for disease in the neck, because that will stop uptake in the neck.
Okay, Lori, your role in next 30 seconds.
Yeah, so I definitely would be thinking of initiating systemic therapy in this patient with the high-grade pathology, the distant Mets. This patient is going to need systemic therapy and probably relatively soon without too much delay. I think one of the questions is in BRAF positive disease in the US now, there's a tissue agnostic FDA approval for dabrafenib and trametinib. So should we go straight to dabrafenib and trametinib in these patients? Or should the standard of care be lenvatinib first and reserving dabrafenib and trametinib for lenvatinib progressive disease? I think that we don't have good level 1 evidence that dabrafenib and trametinib is a better first-line therapy. The small phase 2 trials that have been done don't have as high response rates as lenvatinib does. So in general, lenvatinib would be my first drug for this patient when we start systemic therapy.
Last question.
Can I just say, I would do that before external beam radiation, since this is going to be palliative. Since the patient has distant metastatic disease. You can always circle back and do external beam radiation, but you can spare the patient the toxicity and just go straight to systemic therapy, I think.
There was one question from the chat, Ahok. Do you happen to remember how high his TG was before you took all those lymph nodes out?
Yes, it was
75, 100, 200?
No, it was very high. It was about, I think, 100 or 110.
Yeah.
Okay, so we got.
Can I just ask, like, I think that was great, Ahok, and strong surgeon went in, surgical disease, but
Sure.
This should have been discussed at a tumor board right from the onset. And I guess my question is, was there any consideration of giving the systemic therapy to shrink this down where you could then see its response? I think you beat yourself up a little bit about the first operation. 106 lymph nodes. I applaud you on getting that, and I applaud the pathologist on finding 106 lymph nodes. But good surgery.
They get paid by the number of nodes.
But good surgery, he then reoccurs. We have bad disease. Biology is king. And should there have been therapy first and then surgery? And also, if the surgeons are pushed, I'm always in, well, what are you guys going to offer after? Because we did good surgery and he came back. So just don't tell me to do it again and then say, oh, look, it came back. So can we talk a little bit about that?
Great points, Janice, great points. I mean, this is what we, myself, Mona Sabra, who was involved, and Ellen was very actively involved. And both Ellen and Erik have done a fantastic job working with us and trying to tell us and educate us as to who would be the right candidate for neoadjuvant or targeted therapies. And he felt, since the disease is clinically palpable, it would be more appropriate to proceed with surgery now rather than, because it was in supraclavicular fossa, I was worried that as we wait longer, it may be unresectable. So I think your point is very good. We did discuss this as a group, multidisciplinary team, and I think now he's getting radiation therapy. Let me show you two pictures because these are very rare, and just wanted to show you. This is an 80-year-old female. I operated on her back in 2016. She had a follicular variant, papillary carcinoma follicular variant with 2 foci of vascular invasion. So the tumor was not very big, 1.7 centimeter. She did develop, she did very well for about 4 or 5 years. And then when she was in Florida, she noted a small nodule here. I don't know if you can see this. Small nodule. Her incision for thyroidectomy is here. And now there is a tiny nodule. The dermatologist saw her, did not know what is going on, didn't put in much with the thyroid cancer that she had. She thought this may be a small melanoma or nodule or nodular melanoma, and she took this lesion out in the office with a small circular incision, and this is the pathology. Zubair, this is metastatic thyroid cancer.
Yes, agree.
So now, where do we go now? Janice, she's in your office. She's 80-year-old, otherwise healthy, and nothing is bothering her. The wound has healed very well. The pathologist, the dermatologist says, I don't know anything about this. I've never seen this. Where do we go?
Yeah, I think, I think we've talked about a few of these at previous tumor boards. I think you have to do a wide excision, and then the question is that going to be enough? Will it infiltrate and go elsewhere? But I would just do a wide excision and treat it like almost like a melanoma, and then just watch.
Yeah. So this is again, nothing more to say than the metastatic thyroid cancer. We don't know. The question was, and Mike asked me, is this a recurrent tumor because of the angio invasion, or this is something I dropped at the time of surgery? I don't know. I don't have a habit of dropping things, but he did raise that question. And I don't have an answer to that. I don't know if I'm the cause of this. I have no idea. But anyway,
Ahok, I don't think you're the cause of it. I think it probably happened at the time of biopsy, and that it's seeding from the FNAB before you even got to the patient. I've seen cases like this. Yeah.
You may be right, and thank you very much for bailing me out.
No, you're not getting out. You're not getting off.
Criticize me anytime,
You're not getting off that easy, Zubair.
Yeah, so you know what, I do have to mention that there was a study done by William Vestra, who's at Mount Sinai now in New York, when he was at Hopkins. And this was a very interesting study done on Hürthle cell carcinomas. And what he showed that in Hürthle cell carcinomas, you get these soft tissue deposits. And those soft tissue deposits in the neck are not all the time, or most of the time, not completely replaced nodes. This is an actually angio-invasive tumor, which is tracking in the vessels, and it can show up. So that may be one of the causes. With a 27 gauge needle or a 25 gauge needle, you do not get tracking of a thyroid tumor. I think I think that maybe that 2 foci of angio-invasion, this has been seen in angio-invasive tumors. So I think that may be one of the causes for this.
Okay, Zubair, you're not helping me, but that's okay. I can live with that. Okay, so we did an extensive workup. Everything was negative. So we're just following the patient, see what happens. She's 80-year-old, and we'll continue to monitor her with a PET CT to make sure there's no disease. Let me just show you one more case. This is a young woman, 50-year-old. Many of you probably would not see this. That's why I want to show you. She had a 10-centimeter poorly differentiated carcinoma operated outside in 2007. She came to Memorial with a recurrent disease. She had about 3 subsequent surgical procedures, all with recurrence in the soft tissue, in the thyroid bed. Luckily, her nerves are okay. She received a course of radiation therapy. She recurred on the contralateral side. And this is the picture in June of 2022. Massive disease in the neck, the tumor infiltrating the skin. This is a poorly differentiated thyroid carcinoma. not anaplastic yet. So this is how she presented, and I was very distressed because there's nothing I can do for this patient. Ellen was following this patient very carefully. I think she was on multiple drug, targeted therapies, and he switched a couple of times. And I told the family that I'm worried about this because this is going to fungate through the skin. We see this very commonly, not uncommonly in squamous cell carcinoma, but very rare in thyroid carcinoma. So this was in June of 2022. You can see the whole skin is indurated. This is all cancer here. And this is the picture in October of 2022. The tumor fungating through the skin. I was very unhappy with this because there is nothing I could do for this. This is not a surgical problem. We got a lot of people involved, neuroradiology, angiography to make sure she does not blow up her carotid. But eventually she passed away. I feel very sorry about her. But we went from 2007 to 2022, and Mike was taking care of her for 15 years with a variety of treatments, multiple surgeries. But going back to both the cases, the second and third case, on day one, we know what is going to happen to these patients. And we can literally project, what is going to happen to these patients. And that's where I think our discussion with the pathologists and endocrinologists comes in picture. So that's my last case. I just wanted to show you, I got 2 minutes, so I'm going to conclude by showing, this is our multidisciplinary team. And the most important people here are the non-surgeons, or those who think they are surgeons. I think it is very important, again, going back to 20 years or 30 years, it was me and myself. Now it is me and myself is in the lower strata. It's everybody else. And I think we have learned so much. And not only that, we are able to kind of prolong the life of some of these patients. And the results in anaplastic are unbelievable. I never expected anaplastic thyroid cancer patient, which is surgically incurable or unresectable, living 4 years with the targeted therapies. So I just want to conclude by saying during the difficult part of the operation, what I do, I step out of the operating room. I have a phone call to make to the chairman or to Janice Pasieka or Michael Tuttle. When the tumor is stuck to the carotid artery or the jugular vein, let the fellow do it. If he makes a hole in the carotid, it's his problem. I didn't do it. Otherwise, I was going to do it anyway. So always find an excuse in the operating room. The greatest excuse in the operating room is surgical diarrhea. You can always find half an hour to go out of the operating room. Nobody can ever stop you there. And when you don't know what to do in the operating room, use irrigation. When you don't know what to do in the ICU, use steroids. That will bail you out from 3 in the morning to 6 in the morning. There are 4 stages in the life of the surgeon. The first stage, you learn how to operate. The second stage, when to operate. The last stage, when not to operate. And a smart surgeon has a 4th stage, when to send the patient to Dr. Pasieka. That's the 4th stage, which is very important. And I think this is where I'm going to conclude by saying that always invite the endocrinologist for drinks and dinner. Whenever I invite Mike, he's more interested in drinks rather than dinner, but that's perfectly okay with me. But things are going to change in thyroid. This is my last slide I want to show. The molecular markers, everything is going to change because the German Shepherd now can identify thyroid cancer with 88% accuracy. So we're going to forget about everything else, all other investigations, and go to the German Shepherd. So I have now started to breed German Shepherds in my backyard. Thank you very much. Mike, last word to you.
Yeah, as always happens, I lose control whenever Dr. Shaha is presenting, so I take no responsibility for the last 5 minutes. I will thank for the panelists. Thanks for a wonderful discussion. It was great to sort of walk through these difficult cases. And thanks, Dr. Shaha, for putting all these cases together for us. Have a great week, guys. Bye-bye.
Thank you very much, everybody.
Bye.